We want to thank everyone for attending tonight. We're very excited to have everyone here to do this webinar and the charcuterie board building event. We're on mute and will remain muted during the DAX presentation. And then after that, you can come off mute and go on camera and begin the charcuterie event. If you'd like to ask a question, please submit it in the chat box and we will take questions at the end of the presentation. And then after the presentation, we'll build our charcuterie boards. If you don't mind, the best thing to do right now is just take out your cheese and meats and get them to room temperature, and then you'll be ready for the charcuterie piece. And with that, I'm going to pass it over to Jared and have him come off mute and we can get going.
All right. It's a pleasure to be here with everybody. Thanks for taking time out of your busy schedules, your evenings to be with us. My name is Jared Pillow. I'm Chief Clinical Product Officer at Nuance for Dragon Ambient Experience. I'm an emergency medicine physician. Before I start going on any more slides, though, I want to introduce you to our panel members who are here with us tonight. So I'll have Christy introduce herself and then Dr. Jack Schilling introduce himself.
All right, thank you, Jared. Good evening, everyone. I am Christy Gleaton. I am the VP of Operations for Thomas Eye Group. We are a large ophthalmology practice in Atlanta, Georgia. And Dr. Jack Schilling.
Hey guys. I am currently the medical director of the Cooper Bone and Joint Institute and an orthopedic surgeon specializing in hip and knee replacement at Cooper University Healthcare in Camden, just outside of Philadelphia.
Awesome. Well, you guys, by the time we're done, you guys will love hearing from Christy and Dr. Schilling. They're just two tremendous healthcare minds and super passionate about similar things that I'm passionate about, which makes they're awesome. And that's about making healthcare better and figuring out how do we really make healthcare better for our clinicians and their patients. So here's our learning objectives for tonight. We're going to talk about, how do you reallocate some of the expenses you might use on Scribes using AI technology, and how do you decouple having Scribes in a physician's workflow by using technology. And then the last thing I want to touch on is what are the types of outcomes you can expect in using AI technology, what kinds of outcomes for the provider's efficiency as well as financial performance. And with that, I'm just curious to get to know all of you a little bit more. So I'm having a poll question pop up in front of you right now. And the question is, are you using medical scribes? We'll give you all 20 seconds or so to answer and we'll reveal. Okay. So let's go ahead and share results. All right, pull it over here. So it looks like 9% are always using medical scribes, about 40% sometimes. So it's about half and half using, half not using. So I think we have a good mix of experience and we can talk through this. So why are we all looking for ways to improve our operations, improve the clinician experience and improve the patient experience? It's because healthcare is hard. I mean, it is. And we know that there is a growing burden on healthcare clinicians to do more with less. We know that the clinics themselves, the organizations are asked to do more with less. And providers, we went to school to take care of patients, not write notes. And so we do what we have to, but we don't do the best job always. And 50% of our time can be spent there. And we know that there's a 3 to 5% loss in revenue. And Natalie said I have to move fast tonight, so I'm not going to tell my burnout story, but providers are burning out. And we see it left and right, especially with the pandemic. It's even worse. 64% say that it's gotten worse over the pandemic. And then just think about your last experience as a patient and think about your patients that come into your clinics, and you know that that experience is not optimal and you want it to be better. So I'm going to pause right here and just ask Christy first. What are some of the issues that you guys are tackling at the Thomas I Group that fall under these categories?
Yeah, I think obviously being operations, the biggest challenge, and I can't imagine it's different for anyone else on this call, is staffing. With the Great Resignation and the pool of candidates that you have, when you're losing experienced staff, it's a challenge. And then bringing people on, it has, we've had to get very creative in how we bring people on with no experience. Or just like you said, you figure out how to do more with less. And so continuing to look for, how can we leverage technology to help with this? But that is one of the greatest challenges we are really facing.
Yeah, Dr. Schilling, I'm curious your thoughts on this.
Yeah, I think, when it comes down to burnout, I just think that people are pushed to their limits, and they're looking for ways to keep doing something that they care about, but struggling to find that way. And I would echo some of the things that Christy said. I mean, staffing is a challenge, and so anything you can do to sort of make people's lives easier or to give them time back is something that is worth investing in, and that's exactly what this is, and that's why we're here.
Awesome. Thank you. And I think that leads right into, why Scribes came about. Like, having somebody else in the room do our documentation for us, it came about for a good reason. It's because there is too much asked of providers to be able to make eye contact with my patient, get a really good Press Ganey score, and do all my documentation, right? And so just some of the history behind Scribe programs in the US started in the 70s. I have a funny kind of history with Scribes myself. I did my residency at the University of Virginia. It was the first academic medical center to use Scribes for their residents. So I was spoiled as a resident. I had a scribe who actually wrote my notes. And on the call tonight is actually one of my ex-scribes, Christopher McGuire. And he worked with me in Lynchburg General. And we would drive back and forth between hospitals because I didn't have scribes at this hospital I was working at an hour away. So I would steal him from his cardiologist, who he is working for. Not really. There's no way I could steal him from his cardiologist. I got him on his days off. And I'd take him with me to this ER an hour away, and we would talk about, wouldn't it be so cool if someday there was a technology that could do what scribes do? Because there's some real issues with scribes. So to touch on what Christy talked about, 44% of scribes have no prior experience. We take people who they're intelligent, they're smart, they can learn quick, and we say, okay, we're going to teach you how to write like a clinician. And most of that training burden is placed on the physician. Oftentimes they'll get a couple shadowing shifts, and then you put them with a physician, and the physician's left editing the notes, doing a lot of markup and making sure that those notes look right. There's not much in the way of certification. There's not industry standards. This is one-to-one. You're always going to have a scribe for each physician. And I know that for some busy orthopedists, they might have 2 scribes because they can't keep up with them. And then there's a really high turnover. And I think the average is 6 months for somebody to stay on as a scribe, which makes sense. They're there to get experience. They want to go to medical school, PA school, NP school. And then, although the one benefit is Christopher would go to Taco Bell for me on a busy shift, which I always appreciated. It was the only place open at midnight. But Christy, what kind of things have you run into? What kind of challenges have you run into when you had scribes working in your clinics in the past?
Sure. So it's interesting, just like you said. So when I came onto Thomas I Group, I had doctors with no scribes with one scribe, with two scribes. So it was very interesting, looking at the challenges. And so even a little bit before COVID, we had already started looking at our scribe turnover. So we were running about 35% turnover with our scribes. And just like you said, they are trying to get experience. They're wanting to go to medical school. They want to be a doctor, PA, whatever. And so we didn't have the longevity. And as an administrator, I would see how disruptive it was to our doctors and their clinics. And basically their whole world would fall apart when their scribe would leave after they got them trained. And so we started looking for some solutions. And then COVID hit, which just, in 2020 wasn't such a big deal. I think people were so, they felt so fortunate to have a job to come back to. But 2021 was brutal from a staffing standpoint. And it just kind of escalated the whole situation where not only, there may have been like a gap when a scribe would leave, but now we had even bigger gaps where we just can't even find candidates. And so this was really huge for us because it helped with this, this staffing gap, and it helped with stabilizing my doctors. It was really important from a patient care perspective. We're dealing with vision and some, like potentially vision threatening diseases. And it was important that we weren't canceling our patients and we could take care of them. And so it was a huge component of our success for last year and moving into 2022 with navigating these staffing shortages. I wish I could do it for technicians, to be honest.
Right. Yeah. Well, I'm curious, actually. This next slide, I'm going to totally surprise Dr. Schilling. I'm going to have you, Dr. Schilling, describe, because you use DAX when you work in the clinic. And so when you tell other doctors about how DAX works, how do you kind of explain it?
Well, I explain it, I think, fairly similarly to what these graphics show, because while, I remember, frankly, Jared, you were part of the very first demo that I ever saw for this. And I came with a Missouri attitude of show me. And I didn't, because I just wasn't a believer. And I really remember being blown away by what was generated from that conversation. And now I live that every day. I think there's some nuance to how I deliver my physical exam messaging in terms of making sure that the right things are captured. But the reality is that, you get into a groove and you literally have a pretty natural conversation. I'm not tied to the computer. I'm having a conversation. And between the human element and eventually the AI element, the reality is that the note is generated. It's generated quickly, and it's generated with almost no edits in a way that is really hard to duplicate. And I certainly was never able to duplicate it in the scribe world for all the reasons that we've already outlined. So, this looks too simplistic. It's this simple, and it works that way with over a very short period of time.
You did a better job than I would have done. That was awesome. So now let me just show a quick video for everybody on what this looks like in a clinic. So we shot this video in our customer experience center. So you'll notice there's like a big LED wall. You don't have to have a big LED wall in your clinic to be able to use DAX, but you'll get an idea of how DAX looks in a clinic situation.
Hi, Dave. How are you?
Hey, good to see you.
It's good to see you too. So I know the nurse told you about Dax.
Mm-hmm.
I'd like to tell Dax a little bit about you.
Sure.
Okay. So Dave is a 55-year-old male with a past medical history significant for depression, type 2 diabetes, and hypertension, who presents for his annual exam. So Dave, how are you doing?
Been a crazy year and a half. It's been very stressful. Work's gotten busier. I've moved my daughter from apartment to apartment down at college in Philadelphia. And we actually had a lot of visitors over the summer, so it's been kind of crazy. I'm a little on edge.
Okay. And so are you an empty nester now?
Yes, we are.
Okay. Are you happy about that?
Yes and no. A little melancholy, but for the most part, we're adjusting to life with just the two of us.
Yeah, that's great. That's great. All right, well, tell me a little bit about your depression. So I know in the past, we haven't really put you on medication because you're on medications for other things. What are your strategies recently for dealing with it?
Over the summer, I actually tried beach yoga, and it was great. But summer ended. It's cold out now, so I need to find some other option, something to work. But I want to shy away from medications. Not ready for that just yet.
Okay, all right. So are you thinking more therapy or skiing? You can do that in the winter.
Well, I'm waiting for the snow, but I think I'd like to try therapy first.
Okay, all right. That sounds good. Now, in terms of your diabetes, are you still taking the metformin?
Yes, I am.
Okay. Now, I know in the past, we've kind of talked about your diet. How are you doing monitoring your sugar intake and that type of thing?
I have a sweet tooth. I love red licorice. I really try and keep it to a minimum. I'm not always good about it, but for the most part, I'm okay.
Okay, all right. And so are you checking your blood sugars at home?
Yes, I'm pretty regular about it during the business week. The weekends, because we're on the go, not as frequent, but I do. I try and stay on top of it.
Okay, are they mostly running in like the hundreds or 200s?
Like 100s.
Okay, all right, that's good. All right, and then in terms of your blood pressure, are you still taking the lisinopril?
Yes, I am.
Okay, so no side effects from that?
No.
Okay, and did you get that blood pressure cuff I had recommended? Okay, and are you taking your blood pressures at home?
Yes. Again, during the week, pretty regular. Weekends, on the go, not as frequent, but we do.
All right, and they seem to be okay? All right. So I know you did a review of system sheet with the nurse when you checked in. Do you have any symptoms like chest pain, shortness of breath,
No.
nausea or vomiting, weight loss, belly pain?
No.
Nothing like that. Okay. All right. Well, I want to go ahead and just do a quick physical exam. I looked at your vital signs when you checked in, and your blood pressure, it looks okay. It's a little elevated, about 135/85. I'd like to see it a little bit lower.
Sure.
But for the most part, they look good. So I'm just going to take a listen to your heart and lungs and let you know if I find anything.
You got it.
Okay. So on your physical examination, everything seems fine. On your heart exam, I do appreciate a slight 2 out of 6 systolic ejection murmur heard at the left base. Your lungs are nice and clear. I don't appreciate any carotid bruits, and I do see slight edema of the lower extremities. So what does that mean? It just means I heard a little sound in your heart making a noise. It doesn't mean that it's necessarily clinically significant. We'll talk about that a little bit though, okay? So I went ahead and I looked at some of the labs we had sent you for before you came to see me. Your hemoglobin A1C is a little elevated. It's at 8. I'd like to see it closer to 6. So I would ask you to really watch that sugar intake, okay? And I looked at the EKG that the nurse did before I came in, and that looks good. It's normal. There's no evidence of any heart disease from a coronary artery standpoint, which is really good.
Good.
So let me just talk a little bit about, my assessment and my plan for you, okay? So for your first problem, your depression, I'd like to go ahead and, we will refer you to the psychologist and have you start with therapy, okay? Now, you know that you can reach out to me if you feel like you need to start on any medication or if you need anything, okay?
Sure.
For your second problem, your diabetes, I want to go ahead and increase the metformin to 1,000 milligrams twice a day. And I want to go ahead and order a hemoglobin A1C for about 3 months from now to see if we have to adjust it again. And I really want you to watch your sugar intake, make a food log, okay?
You got it.
And for your third problem, your high blood pressure, let's go ahead and increase the lisinopril to 40 milligrams a day. And I want you to continue to check those blood pressures for me and report them to me in the patient portal, okay? And lastly, from a preventative medicine standpoint, unfortunately you're due for a colonoscopy. So I'll go ahead and schedule you for that, okay?
Wonderful.
Do you have any questions?
Not at this point, no.
Okay, it was good to see you.
You got it.
Hey, Dragon, finalize the note. Bye.
Thank you.
All right. Now, my team who put the slides together, you're going to notice I'm jumping around because I'm trying to stay in our time frame that you gave me. But what I want to show first, before I want to show you all the AI draft note, what the AI did with that conversation and what it wrote. But before I do that, I want you to understand what we saw happening was this audio capture. Now you can capture that audio using an iPhone or an iPod, or you can use something like Microsoft Teams where we have an integration. That audio gets captured. It goes up to our AI cloud. And what happens next is what we call speech diarization. It's where the patient and the clinician are separated in their transcripts. You could have multiple people in the room. It'll separate everybody, even screaming babies. Then those transcripts go up to our AI cloud to natural language generation, where the note is written. And then that goes to a quality review step. That's a person trained up in whatever specialty you specialize in. So for Dr. Schilling, it's orthopedist. For Christie's team, it's ophthalmology. They review that note, make sure it's as close to 100% perfect as possible, and then it's placed in the EHR. So with that explanation, now I'm going to show you what the AI note looked like. And I know that it's a little bit difficult to read, but you can see over here first, I guess I'll explain. Far left, this is the speech diarization, the separation of speakers. And then right here, this is the AI draft note. And I'll kind of be quiet. You'll notice it's not perfect, but you'll start to catch where we're headed with this and why we're so excited about what the AI can do. And then of course, over here on the right, this is the final note. So this is after it goes through that quality review check. It's the final note that gets placed back into your EHR. And I'm curious, Dr. Schilling, your user day in, day out in the clinic, how long does it usually take you to review a note once you go into your EHR?
You know, we were talking about this before. I've been doing this for about a year. And what I would tell you is that in that period, that answer's changed drastically, where, I mean, it's probably never been more than I'll say 5 minutes a note, just to be conservative. But I am literally now in a place where I am looking at the note, scanning it, knowing that it says what I need to say, and being done in about 30 seconds. And that is, you know, human element, understanding what I'm doing and learning from me, and eventually, you know, the AI kicking in and doing what I do almost instantaneously. And that was also with, you know, turnover times, you know, that were a couple of hours in the beginning that are now down to much less time. So it just doesn't take much anymore. And that's, I mean, it takes time to get there because it's learning from you, but it will get there. And I'm looking at the questions coming through. There's so many good ones. I'm telling you, I was in the same place and it just works.
Yeah, that's awesome. So real quick, just what are some of the outcomes that our users, our clinicians are experiencing? To me, this is the big one. It's this time savings, 7 minutes per patient, average across specialties. So that varies per clinician, but it's about 2 hours a day. And then this next one, you know, 70% reduction in feelings of burnout, 93% would be disappointed, 9 out of 10 recommend it. If you've ever worked with physicians, you know that's a crazy high number. If you can get 50% recommending something, you're pretty happy. And then I love this patient experience column over here that 80% of patients feel like their doctors are more personable, conversational, focused, less time on the computer, more time on them. And then we do work with you. If you want to make sure that we're seeing financial outcomes, we'll make sure that you can have a really good ROI. And it really comes down to saving time. Some clinicians decide to add patients. But what I want to do now is just hear from Christy and then Dr. Schilling, kind of what the outcomes are that they've had at their specific locations.
Sure. You know, we've been really fortunate with this. We started off, so we have a lot of specialists within our practice. We started off an oculoplastic surgeon and then one of our glaucoma specialists with this. And, you know, the success for me has been stabilization for our doctors. Just as I mentioned, from a staffing standpoint, we've had people out with COVID. We have had staff leave, and we did not have to reduce the doctors that were on DAX, their schedules or capacity, they were able to keep taking care of the patients. We have some of our doctors that we put on DAX that did not have a scribe. We were able to increase their patient volume actually, for them to actually be able to see more patients. Just as Dr. Schilling said, it was saving them time and documentation. They're able to focus on the patient. We have seen an improvement. So one of the things that I, as an administrator, loved about DAX, and I'm sure many of you have to deal with this, and it's a frustrating point for doctors. I used to implement EMR systems, is macro and MIPS and dealing with all of that stuff. And so part of our onboarding when we started working with them was to share, these are the measures that we participate in. This is how you meet it in the software system that we use. And so they make sure that documentation gets in there. So our measures have actually improved for a reporting standpoint. And we have actually seen a greater, better feedback from referring doctors. We also ask that they send out the letters, referral letters for doctors that have sent us patients. And I've seen from some primary care doctors, other doctors that I've interacted with, where they said that when we did this, they noticed that they were getting more of those letters than they used to, because sometimes those are the little things that slip through the cracks and that communication from a patient standpoint. So we've had several wins moving to this.
Awesome. And Dr. Schilling, you at Cooper, the team at Cooper, what kinds of outcomes have you guys seen?
I think our outcomes, I just can't get the 83% patient satisfaction, and physician chattiness makes me laugh a little bit, because I've actually caught myself, I'm so not chasing the time the way that I used to chase the time, that I'm almost too chatty sometimes now. And I have to like check myself to say, cut yourself off. And I on the administrative level, you can look at this and say, well, we might be able to see more patients. We might be able to do these things. I think that the real selling point to the physicians and the providers in general on the call is that it's giving you time back in your day that you don't, there's very few things that give you back your most precious resource. And it really does that. It's done that for me. It does improve patient experience, but it improves provider life experience. You're not doing 3 hours of work in the evenings trying to get your notes cleaned up. There's a lot of things on here about marrying it to different EMRs and different types of templates. I'm a very templated person. I always was. I've given my templates to DAX, and that's where we started. And it's worked. Accents, don't really matter. We have figured out ways to work around translational issues with non-English speaking patients. So all I would say is give it a try, because I really believe that if you can get past some of your initial concerns, that the outcomes on the other side are going to be what you expect. And I was a non-believer the first time. I did not believe what was going to happen, but I am all in all the time at this point.
That's awesome. I love the idea of you sitting there getting lost in conversation and not paying attention to needing to spend time catching up. That I'm sure that's a different feeling for your clinic staff as well as yourself. Which
they're giving me a hard time sometimes, because they think, that I like to be chatty anyway, but it's almost made it worse at times. So, but that's a good problem to have, because people are happy and the patients are happy, and I still get done more or less on time. So that's a good thing. No,
that's great. That's great. Well, I know we're getting to the point where you're all looking forward to charcuterie, but I'm just gonna bring Natalie back in and see if we have time for any questions. I know Dr. Schilling, actually, you tackled a bunch of the questions that usually come up there in your last answer.
Sure, Jared. There's a lot of questions about integration with EMR, and I know Jack talked about it a little bit. Can you talk about that a little bit more? There was a question about Epic, Athena. Can you just talk about that?
Yeah, almost every major EMR. I think there's a list of 20 different EMRs that we work seamlessly with. We need to get an ADT SIU feed, so schedule feed, to be able to populate the application so that you can pick out your patient. But other than that, I mean, super easy. We've got some more advanced integrations with some of the larger EHRs like Epic and Athena. The Hey Epic functionality is a nuanced technology. We're actually testing something called Express Mode, where we let a clinician see the AI draft note within seconds of finishing. And we're testing that in Athena today, soon to be Epic. So very deeply integrated with the EHRs.
Perfect, thank you. Another question that came up is how does the data get stored and how is it kept secure?
So it's all stored in our HIPAA compliant Azure cloud. And as far as data retention goes, we do retain the data for 3 years. And during that time, because the way AI models are built is they're trained at a certain period of time, and you want as much data as possible at that period of time. And so we keep that data for 3 years. After 3 years, it's de-identified or destroyed. What's really interesting is I've had a lot of people worry about the liability of that data being around. But what I've seen over and over the years is clinicians and clinics use that data as protection. So saying, hey, I want to pull up this recording and listen to it and prove that I was right. And that has happened hundreds of times, while I've never actually seen the data asked for any kind of court proceedings or anything like that.
Okay. And a couple other questions. I'm gonna ask these kind of together, but can you talk about the background noise and how it works with background noise, crying babies, things like that? And then also how it works with accents and different accents with the doctors and the patients, and whether or not it comes in other languages.
Yeah, so maybe I'll pull Christy in. Is your clinic like dead silent? Never any crying babies?
I have pediatrics. I have quite a few pediatric providers, and no, we have a separate waiting room for all our crying babies. I will say that was probably one of the biggest concerns for my my pediatric ophthalmologist, and they're actually very pleased with it. And so whether it's older adults and accents, things like that, we use language lines, a translation service. So I've even had my doctors tell me that has worked really well with DAX, because they'll have that going and still able to work with patients from a translation standpoint, and still be able to utilize DAX. So.
Perfect. Thank you, Christy.
Mm-hmm.
Just a side note, there's a couple questions in the chat about cost and how you can get started with DAX. And we will follow up with you in the next few days, and we can talk to you about that. Let's see, just looking for questions. I think.
Do we do it? We got them all?
Well, there was a lot of, a couple that were similar. I was trying to find there's a question about templates and whether DAX integrates with templates. Can you talk a little bit about that?
Yeah, I'll touch on it quickly. Dr. Schilling talked about it, that he has lots of templates, pass those on to us, and we work seamlessly. So yeah, no problem with templates.
Okay. All right. And I think with that, we are going to pass it off to Kerry for the charcuterie board building. So if you'd like to turn on your video to participate, please feel free to do that. And we'll pass it off to Kerry.
All right. Do I need to leave this slide up to introduce Kerry, or should I take it down, and Kerry, you'll introduce yourself?
I got it covered.
All right.